Welcome back to Patient No Longer. We have ourselves a very intriguing guest today, and I'll get into more of that. But first, to introduce him, we've got Hal Andrews, President and CEO of Trilliant Health. Hal, thanks for being on today.
Thanks for inviting me.
Well, it's good to have you here. You're a healthcare business leader. You've got a lot of experience, over a quarter century of experience as an entrepreneur. You've been an executive and an investor. And we're going to talk about affordability, we're going to talk about pricing, we're going to talk about costs today. But you serve as President and CEO of Trilliant Health since its founding in June 2017. You also serve on the board of directors for Trilliant Health and employer advisor, and on the board of advisors for Nashville Capital Network. And we'll link to your bio. You've got a great experience and a long history in healthcare. Not the first industry you were in, but we'll come back to that. I want to ask you, though, with your perspective, sometimes we hear that healthcare doesn't really change that much. I've heard a glacier analogy out there somewhere. And yet at the same time, when I listen to you, I hear a lot is changing. And so I'm curious, with your perspective, and if you run into that person that says, I don't know how much healthcare is really changing, where do you stand on that, and what would your answer to them be?
I think anyone who thinks that healthcare isn't changing doesn't have the data. And I think healthcare changes monthly in both micro and macro ways. And I think that to believe that it is static is a fatal mistake if you're a strategist.
And it's so interesting because I've had folks in strategy. I mean, we talk a lot about data. NRC Health, the R is for research. We have plenty of data, and you do too. We could have a really nice, data off where we show data. But you'll get people who go through a huge exercise, a workshop, what have you, and it doesn't seem like their strategic planning changes all that much. I was actually in a retreat where someone asked, what was our strategic plan 5 years ago? Was it all that different? Do you think there's a disconnect between the actual changes? I agree with you. Change happens monthly in our industry. And what people as executives or leaders actually experience? Is there a gap there somewhere?
Well, one of the things that I do is every day I read The Daily Drucker by Peter Drucker.
Sure.
And as it happens, yesterday's Daily Drucker was about the difference between strategy and planning. And I think healthcare companies do a whole lot of planning and not a lot of strategy. And I think they're sort of lulled to sleep. And the planning sort of fits in with your first question. If you look at planning, it's an exercise, and it's an annual exercise. And then we do a 1-year plan, and then we update our 5-year plan, and then maybe we have our 10-year plan. But we do that with incomplete and legacy data, and we sort of lull ourselves to sleep into believing that nothing's changing when lots of things are changing. The other thing that happens is Peter Drucker talks about how change for public service institutions is usually brought to bear by outside forces or a catastrophe. And so if you look at healthcare, I think most healthcare companies and certainly most hospitals are sort of stuck reacting instead of being proactive. They're reacting to this change in this regulation or a new drug like Ozempic. And so it's not really ever, it's easy to excuse the fact that they're not really proactive because they spend so much time being reactive.
And that hurts them, and I think they don't always realize it. I'm a Drucker fan too, and you mentioned strategy, so there's an old Drucker quote about culture eats strategy for lunch.
Yes,
so I want to
breakfast and dinner.
And dinner, and maybe a night snack.
Yeah.
So let's talk about culture for a minute. We're gonna go into lots of topics with your background, but where does culture fit into that too? In other words, maybe I'm good at strategy. Maybe I'm mixing in strategy and planning in the right way in a balanced approach. Can culture truly be a barrier to executing that, and how do you navigate that?
I think culture manifests as adherence to the status quo in healthcare. And so I think your reference point there is actually the Wizard of Oz. There are a lot of people who lack courage. There are a lot of people who think they know what the right thing to do is, and a lot of them are right. They do know what they should do, but they're too scared to do it because they're too comfortable. And I think to really have a culture that adapts to change and sort of leans into change, and in healthcare we need to be leaning into it because we have a lot of headwinds. but that takes courage and it takes stamina. And, there's the old cartoon about the speaker saying, who thinks we should change? And everybody raised their hand. And then he says, who wants to change? And nobody raised their hands. Right? Change is hard. And one of the things that I've learned over the years in doing what I do, which is really leading a group of people who've been together a long time to fix broken companies. When you get near bankruptcy, which is where we usually show up, people say, hey, we're about to run out of money. Can you guys fix this? There's nothing like that to force change, because it's either not pay the bills and turn out the lights or change. So I have a lot of experience doing it, but I have a lot of experience observing it.
Your point about coming in when someone says, yeah, we're near bankrupt, I can think of an analogy in our work at NRC Health of our numbers are really going down. Can you turn them around? And there's so many things that have already happened. And then you talk about the pressures of today. So I love that you used headwinds. We had a guest on a couple years ago, Mike Slabowski, Trinity Health CEO, who talked about how we already just before we do a thing, we face these incredible headwinds in healthcare. You have economic headwinds. Right now we've got the crisis of access. People want to come to us, they can't. We're also fighting in the winter, COVID, RSV, flu, all these things coming back around. So you have these incredible, incredible headwinds. Culture seems to me that's something that people should be actively working on all the time and trying to build that proactivity. I don't hear courage talked about much. You use that word, and I'm trying to place it somewhere. I almost think in some ways in healthcare, maybe culturally, maybe not, we're expected to not be courageous, not be too leading edge, because there's safety, there's quality, there's all these things that we have to protect. And, you don't want someone coming in, doing anything too different if it's, variation of care, those sort of things. Do you find in healthcare you're able to break through that and show them where courage is very much a good thing and where they need to adopt it more?
Well, I don't think I can take credit for that. I think, though, that the more you understand reality, the more courage you'll have. So back to your safety and quality examples. If you look just at a simple thing like readmissions, when 2007 CMS said they wanted to do readmission penalties,
right,
no one could really stand up and say, no, that's a bad idea. We're for readmissions, right? So everybody says, yeah, sure, we're readmissions penalties. That's just a good thing.
Yeah.
And CMS said, well, we think the readmission penalty should be 5% of your revenue. And everybody said, oh, no, we're not that much in favor of doing that. How about a quarter of a point?
Yeah.
And so what's the result? In 2024, almost half of the hospitals will be penalized for readmissions. And so if you pretend that the truth is not the truth, then it's easier to sort of hang it back saying, well, I don't really want to do this thing. But if you're really facing the facts about your organization, about how healthcare is doing, one of the things that's most alarming is that post-discharge mortality is up since 2022, excluding COVID cases. Post-discharge mortality for pneumonia, taking COVID out of it, post-discharge mortality for pneumonia is up 18%. Well, I think people should be sort of concerned about that.
Yes.
And I'm the only person I know who's even talking about it. And so if you're ignoring the fact that post-discharge mortality is up for stroke and heart attack and pneumonia, well, it's easy not to do anything. We just sort of close our eyes, and either that or we look at it and say, well, but everybody else is doing that too, so why do I need to do something?
That point on the sameness, I think, is so true, because when we say courage, and I love that we kind of just dug in on this, it's not like people are out there saying, I'm not courageous. And, there's not people saying, well, courage is a bad thing. In fact, our frontline workers are courageous every day. Mm-hmm. But it's really easy to look around you and say, well, nobody's moving this direction. I don't have to move this direction. That's not even really about fear, but it's certainly not about courage. And so it's easy to kind of blend into the sea of sameness and sort of get by. And then we miss the effect of that on the actual patient.
Well, so that's a great example. And so let's get real here.
Sure.
On the frontline workers, we expected them to be there, the nurses and the technicians and the ambulance drivers, and a bunch of the rest of us decided that work from home was pretty cool.
Yeah.
And we have a big disconnect between the people who are actually doing the hands-on patient work and the people who are administrative in some way or another. And that distance also allows you to sort of not pay attention. There are a bunch of folks who still haven't come back to work, both on the provider side and the government side. And to your point, if you don't see it every day, it's a lot easier to ignore it. But if you're on the front lines with your team, it gets really hard to look at people who are digging in and doing the hard work and struggling and ignore them unless you're completely heartless, which, again, that's a Wizard of Oz character as well. But
Sure.
I think this work from home thing in healthcare is, I think, a real long-term cultural problem because it creates a perception among the people on the front line that there are different rules for them than there are for people in administrative positions.
I completely support where you're going with that because, while I think every culture within every organization is different in how they've handled work from home, we've really learned that it's not a one size fits all. But I do think, there's times when I've heard from folks on the inside, colleagues, caregivers, administrators who say there's some initiatives where the people telling me to do that initiative are all working from home all the time. And there's something about that. Like, I feel like I'm here sort of in the trenches. Mm-hmm. And if I don't feel like other people are at least here some of the time, it's a problem. And it affects our culture.
Oh, absolutely. And that's a mark of leadership. I mean, there's some places where it's not only are they working from home, they're working from several states away.
Sure.
Now, again, we have over half of our employees are engineers, and they're writing code, and they can work from anywhere.
Same here.
And that's fine. But for a leader of an organization to be 3 or 4 states away and never on the front lines creates a cultural problem for sure.
Completely agree with you on that. And before we get too deep, I've always got to do this in every interview. So I think this is good timing. I'm really interested in your results because we do a little speed round. These are we're taking a little break from healthcare.
Okay.
And they're quick ones. You don't know these questions, but our listeners, many of them know these questions by now. And just top of mind.
So that sort of exposes me that I'm not a listener, that I don't know the questions.
You're not a listener yet,
Okay.
Hal.
I didn't know. I will.
Well, they change too. So
Okay.
That's the other thing. I've had people say, I didn't hear those before. Well, that was a previous season. So this season speed round, Hal Andrews on the spot, Coke or Pepsi?
Coke.
No hesitation in that. Fiction or nonfiction?
Nonfiction.
Morning person or night owl?
Morning.
Favorite movie or TV show of all time?
Raising Arizona.
That is the fastest answer we've ever gotten on favorite movie or TV show, and that's a fantastic movie. Last one, East Coast or West Coast?
East Coast.
Okay, very good. That was incredibly efficient.
I'm doing what I can here.
Well, you're doing great. So I want to dig into something that I've heard you speak about and talk about, and I know Trilliant Health consults on this quite a bit. And that's specifically about the price we pay as patients. Often gets described as price transparency, cost, all of those things that are, of course, a huge issue for hospitals, but they're a huge issue for patients and their budgets. One thing that I've noticed in the research NRC Health has done is it's not just about the price you pay out of pocket. It's the mystery of it that sort of haunts you throughout from the very beginning. What is this going to cost me? How much am I going to pay? Can I afford this? And the additional anxiety that provides people as they're, going through a healthcare experience, which can have its own anxiety. So I'm really curious your thoughts, not only on price transparency or the lack thereof, how it affects patients, but also as an industry, where we're going with this issue.
So the first thing that comes to mind is another movie, which is Elf, which has got to be the top 5. So you remember the scene where Buddy the Elf he's sort of been put off to the side to test the Jack in the Box.
Oh, yes.
Right? And he's got the defective one and he thinks it's not going to pop, and then it pops up and it scares him. And I think that's healthcare for most Americans. I think so there are 2 parts of it. One is, and your data on it's probably better than ours, we now have half of Americans who are struggling to afford with healthcare, to afford their healthcare. And I think that is a problem that's a data point that I think everybody knows, and not enough people are sort of digging in and thinking about that. And we want to believe that people will struggle with their healthcare costs, but still pick us because we're better. We're more famous, or we're more convenient, or whatever that thing is. And what our data shows is that people are increasingly foregoing care or delaying care. And when they pick, they actually pick on access, not in terms of, is this convenient to me, or is this my favorite brand, but can I get in the door? Because we have also a well-known shortage of physicians. So I'll use myself as an example. I was at Vanderbilt Internal Medicine with my primary care physician, who left to go join the Frisk Clinic, which is part of HCA, and then he left to go open the new medical school at Belmont University. And when he left Belmont, to go to Belmont, he said, I'll get you in with one of my partners at the Frisk Clinic. And I said, great. And then earlier this year, I got a letter from that physician who said, I'm leaving medicine. I'm going to go do telehealth. And good luck. And we don't have room for you at the Frisk Clinic. And it took me 6 months to find an internist in Nashville, the healthcare mecca. And I had to call in a favor. I had to call a department head at Vanderbilt to say, I need a physician. And he said, well, do you have any preferences? And I said, well, someone younger than me, so they'll outlive me. But other than that, no, I can't find one. And if we have a supply problem in Nashville, Tennessee, then we have a supply problem in a lot of places.
Everywhere.
And so people they're waiting until they can't afford to wait anymore, right? Where the physical cost of waiting outweighs the economic cost. And I think that's a huge, huge problem for everybody, because that results in a diagnosis of a disease state later when you can't intervene with as effective a medication from a therapeutic standpoint or from a cost standpoint.
And actual patients get caught in the middle of that. In your case, because of those other changes, with physician and administratively, and going from this organization to that, you were just sort of dropped out of the bottom of that.
Correct.
And that's your experience. And I agree with you. We've got plenty of data as well that people are deferring care. 1 in 4 Americans in 2025, coming into 25, are putting off care. And it's not always because of cost, though cost can be part of it. The perception, that pain, that jack in the box, is it going to come out this time? But also the access issues that you underscore. And on the other side of that is this idea that, but we've got a powerful brand and a strong reputation, and your experience will be worth it no matter how long you wait or how much it costs. On this season of the Patient Owner podcast, we've had academic medical centers talk in a very real way about, that's not always the draw for everybody, especially if you have to wait a long time. And there's got to be ways to sort of go to the patient where they are, whether you're an academic, whoever you are, however strong your reputation is, to go to the patient. Do you see that changing at all? I mean, you're good with the pure economics of this. Are patients going to have someone come to them and say, we can find a way to get you in? Or is that a little bit of a pipe dream in healthcare?
I think it's a pipe dream. I think the irony of the situation, the scenario you just described, is that it most resembles Cuba. And, historically, Cuba had a physician assigned to a block or a neighborhood, and the physician rounded on the patients when they needed to see them. And if you look at the value-based care platforms that really worked in Miami, two of those were founded by Cubans. And I've been in a lot of healthcare facilities in my life, like well north of 1,000, because that was sort of my job, to go around and look. And I've never walked in a place and seen people who look like they were having a good time, except in Miami at one of the Leon health centers. And when I walked in the door there, because I was sort of scouting it out,
Sure.
the first thing my first sense was the smell of Cuban coffee. And the second sense was there was salsa music. And the third sense was I saw a bunch of old men playing dominoes. And that's the first and only time that I've ever seen people who looked happy to be there. So I think the jumping off point is, as healthcare providers, we convince ourselves that it's actually going to be a good experience. When, to your point, people are scared. They're scared emotionally. They're scared of, what's the doctor going to tell me? Is it going to hurt? And they're scared that they don't know what it might ultimately cost. And I think if we don't look at that and acknowledge where people are when they hit the door, and that's in a non-emergent situation. Think about the emergency situations, right? We're dealing with people in a crisis. And again, I think we just sort of gloss over as a system. Now, I want to be clear, I'm not talking about, there are a lot of people on the ground, nurses who are amazing at getting people to sort of calm down, to feel like it's going to be okay, even if the nurse knows that it's not going to be okay. But as a system, we sort of gloss over the reality of what it's like to be a patient.
Your point is well made, and I think this is a problem across the country. It's not any one brand, because you have these organizations that are saying, well, we have a great reputation, we provide a great experience, that should be good enough. But to your point about those people on the outside saying, yeah, I've had to wait a long time, this is going to cost a lot of money. If I don't walk in and hear salsa music, if I walk in and see sad folks who don't really care if I'm there or not, that experience payoff is not there. Mm-hmm. And that's going to continue to be a challenge as healthcare continues to get more expensive. So one thing I'm curious about, and I've been asking everyone in this season about, is those who are attempting to disrupt from the outside and intermediate whether we want them to or not, we being maybe hospitals or health systems. You've got your Amazons, your Walmarts, your CVS. This is a really interesting time in disruption because it's kind of a locomotive that keeps on going. And yet we've had a few people jump off the train for now. You've had, Walmart, CVS, some that are clawing back some of those resources. Amazon's still chugging along with One Medical. But I'm curious, with all you know, your take on those sort of quote unquote disruptors, and if you think they're going to make a difference to patients and the current sort of lockup that we have.
So I think the jumping off point is that most of the disruptors, except for Walmart, all of the disruption is an urban model disruption. Mm-hmm. And the things that work in New York, LA, Chicago, Dallas, Miami, I mean, they sort of work across a broad spectrum there depending on population density. So in New York City, where you got 50,000 people per square mile, it doesn't work like Dallas, where the Dallas Metroplex is a huge area. But beyond that, rural healthcare is just different. And Walmart is the only one who had a chance to do primary care at scale in rural America, and I was deeply hopeful that they were going to. The fact that they pulled back, and in their announcement that they were pulling back, they acknowledged that they were leaving a bunch of healthcare professional shortage areas high and dry, was a data point. Yeah. Maybe the more important data point was they said, but we're still going to do specialty pharmacy. And so I think if you look at Amazon and CVS and Walgreens and Walmart, they're really in the pharmaceutical distribution business, which is not the same as the primary care business. And that introduces a broader threat to traditional healthcare providers of what I call hands-on medicine. So hospitals and clinics and surgery centers and doctors' offices. The people who are trying to promote drug therapies, some of those drug therapies are great, some of them are average, some of them don't actually work. But there's sort of this existential threat emerging between people who are in the pharmacy distribution business and people who are in the I'm touching the patient business. And I think that's probably the most transformative thing that will happen over the next 15 or 20 years in healthcare. And again, it didn't take long for, it's always funny as somebody who's been in healthcare my entire career to see people come in, they're usually from California, and they just look and go, you guys must be stupid because this can't be that hard. And it's sort of funny to watch Amazon and Microsoft and Google and CVS and all these people struggle with the reality of delivering healthcare service. But it's also a foreboding sign for all of us who do hands-on healthcare that they all decided, you know what, we can't do that, but we can be really good at specialty pharmacy.
And it's a great way to delineate and talk about things that are not hands-on and things that are. I love the way that you partition that. And of course, you've been in healthcare a long time to see the difference. but you haven't been in healthcare your entire career. You previously worked for a pro wrestling company, professional wrestling. And we talked about this before, and I quite enjoyed this exchange as a pro wrestling fan myself and growing up with it. But I got to ask you, Hal, since I have you here, what is something you learned from the professional wrestling business that applies to your work in healthcare today?
Well, a macro and a micro thing. The first thing is, and this is also true of anybody who's ever worked in a retail environment, when you're on the road for months at a time across all of America, and particularly with the wrestling fans, you see the people as they are. You get a real hands-on experience with the people in America. And again, I think as a broad stroke, a lot of the things that we do from a policy perspective in healthcare are by people who are well-meaning, but they're sitting in D.C. and they don't get out of the Beltway much, and they don't know who these people are, and they don't know what they need, and they don't know what they want. And so you're never going to meet the definition of what the customer wants if you don't even know the customer. Back to Peter Drucker, he talks about the fact that the test of innovation is whether it creates value for the customer. Well, if you don't know your customer, you're probably not going to get it right in trying to serve them. I think the second part, and this is an interesting thing in terms of affordability, some of the places we went, I was up close personal with poverty, right? And I'm only 2 generations removed from that. My grandparents were literally dirt poor, living in a house with a dirt floor and no plumbing. And I try not to forget that when I'm staying at places like this. But what you saw was that for something that was important to them, for something that would bring them joy, they would do whatever they had to do to save money to take the family. And I would have a pang of guilt knowing what the prices were. And it wasn't like a Taylor Swift ticket. It was like, $25.
Sure.
But if you brought 6 kids in some of the places we were, you knew that they had really done everything in their power to save money, to create that experience for their family. And so back to experience, people would be more willing to lean in and try to afford the cost of healthcare if it were something that was a positive experience. But for most of them, it isn't. It's a negative experience.
Very well said, and I'm so glad those lessons translate. And your point about knowing the customer, could not agree more. So one more question for you.
Okay.
And I think the person on the other end of this would really benefit, because you're getting in an elevator and somebody else squeezes in, and it happens to be their first day in healthcare, and they turn to you, tell you that, and say, "What's a piece of advice you'd give me on day one?"
So the advice is simple: be an expert. The application is simple: read a lot. And so I started in healthcare in 1991, and one of my mentors, for whom I worked twice, was famous, and this is before the internet for some of your listeners who don't know what it was like back then. He would actually read based on the articles in newspapers, the physical newspaper, the physical article.
Sure.
And he would then copy articles. And another thing that some of your listeners won't know, in the old days, you would put a cover sheet, which was a memo with everybody's name that you wanted to read it, and then it'd circle around the office. And after you read it, you'd check your name off and hand it to the next person. And he would copy these articles and distribute them to the management team. And at the time I first worked for him, I was 29, and I didn't know anything. And sitting in my office today are a couple of bankers' boxes full of the articles that he gave me, and they were very broad. And so you've got to read a lot, and then you have to read from a lot of different perspectives. And then you have to think critically. And if you're committed to being an expert and you're committed to doing the work, and then you commit to think critically and to do the triangulation yourself and not just read somebody's summary of it, then I think your career will be much more rewarding.
Well, you've encouraged us all to think critically, and also that point about be an expert, because there's listeners who think, well, I'm not an expert at anything, but you can be that and sort of become that as you go. And that's just fantastic advice. Hal, I want to thank you so much for the whole perspective, everything we covered. We got into some deep issues, and it was just really a pleasure to have you on the Patient No Longer podcast today.
Well, again, thanks for inviting me.
All right. Thank you.